Hi, and welcome to the MedTech Insider, your inside look to all things med device. My name is Parker Snedden, and I will be your host for today. We have an awesome guest with us today, Dr. Chad Stevens out of Fort Worth, Texas. Dr. Stevens, you and I have known each other for about 4 or 5 years now. You've had such a huge impact on Spinal Simplicity, on just the interventional pain market as a whole. So, man, it's my privilege to have you on as a guest today.
Thank you. I'm really honored to get to come up here and chat with you. It's going to be a great time.
It's fun to be in Kansas City, right?
It is great, except there's a football team here that lost to the Cowboys a couple weeks ago, I think. I'm not sure.
What? We were on a text thread about that, and I gave you a bunch of crap, and you guys beat us.
We did. We played better that week than we did last night.
Yeah.
But we'll just leave it at that.
Okay. Yeah. For those of you that don't know, the Cowboys beat the Chiefs on Thanksgiving. Most of you probably watched that game.
I'm sure everybody saw that.
Yeah. That's awesome. Yeah. Well, we're going to talk about a variety of topics today, including the just aging spine care in general.
Absolutely.
But I want to start by giving the audience just a flavor of your career.
Sure.
You've been doing this a long time now, made a huge impact in the market. So just give me some milestones that you've hit in your career as a physician.
Well, thank you, Parker. So I guess I would have to kind of start with my upbringing through medicine altogether. I went through medical school. Was very interested in ear, nose, and throat surgery because I had a background in missions and wanted to be able to do some cleft palates and cleft lips and things like that in the spiritual situations where I could help people, and it kind of was my goal growing up to do that. But when I went through all of my different rotations, I found that I needed to find something where I could help people the majority of the time and harm them rarely. Okay. One of my ENT rotations I was on, the doctor that was a very accomplished doctor accidentally doing a prostatectomy, accidentally paralyzed a woman's face. And doing a prostatectomy, you can hit the facial nerve, and he accidentally dinged that. And she didn't have a facial, movement on one side of her face, and she was a young lady. And I said to myself, that's something I would have a very hard time dealing with, right? There are surgeons and different doctors that have a really good ability to throw an interception, for lack of a better term, and then come back and throw a touchdown the next play, right? But I'm kind of bad at forgetting about that interception, right? So when I went through my rotation in sports medicine and pain, I saw in that a intrigue that I could work my way through different diagnoses and come up with good treatment plans for people, and yet be able to do things for them in a procedural way that had low risks and be able to help them so they can achieve some of their goals and dreams, right? So that's kind of how I started in pain management. And I thought, I'm just going to kind of have this career where I'm going to do kind of the basics of pain management, and it's going to be completely satisfying to me, and I'm going to go about my business and have a wonderful life. And what I realized in my first group I joined in Indiana, working with a bunch of orthopedic surgeons, is I thought a lot like the orthopedic surgeons. I wanted to do something that made things better for the long term, not just the short term, and I wanted to make a big difference in people's lives, but I still wanted to have minimal complications, and I wanted to do things safely, and I wanted to be very cautious. And that group kind of stretched me a little bit. They kind of taught me that maybe my skill set was larger than I was using. And so I ended up leaving that group and coming back to Texas, which is where my wife's from, as you know. And I think when you come back to Texas, you end up staying in Texas sometimes.
It's hard to leave.
It's hard to leave. And now, especially all our kids are kind of finishing their lives, starting their lives actually, rather finishing their schooling, starting their lives. Looks like they're going to kind of settle around us. So, but what I did there is I went back and did the fellowship in pain management after the sports medicine background I had. And so what I realized is there's a lot of procedures I could do that could help people. And so went on to my job at Indiana. In Indiana, I realized that I wanted to do more. And so I started to then look for additional fellowship training. So I got additional, what we called advanced fellowship training. And that was in kyphoplasty, more stimulators, and more diving into the surgical aspect of and pumps and how to do the higher end pain procedures, which were at that time those things I just mentioned. Obviously, in the last 10 years or so, things have really developed, even the last 5 years have developed dramatically. So I went back to Texas. I did a ton of stimulators because that was kind of what was necessary. I was in this county that didn't have hardly any pain doctors at all and had a whole bunch of people who had been operated. And I was either going to come in and have to really narc people up, which I didn't want to do, or develop the skill set to help them in ways that they needed. And so that's kind of my first start in Texas. And then as I've gone through the years, I realized that there were patients coming to see me, Parker, that had problems that I didn't have the tool to fix. So something as simple as like a migraine, something as complicated as like these minimally invasive procedures we're going to talk about a little bit today, those all became necessities because of the patients I was seeing, and I wanted to have a tool to treat them. And I had to realize that I had the skill set and the knowledge and the want to do all those things. So fast forward a little bit, I left some of those jobs in Texas, worked my way into other jobs, and I realized that I was still not using all the tools I needed to use. So I got into this minimally invasive spine world. And the minimally invasive spine world was very intriguing to me because I felt like for the first time, I wasn't just, although I love stimulators, I don't want to belittle that, but I wasn't just stimulating something, I was actually trying to fix something, right? And that might have been that orthopedic kind of background I had where all my partners in Indiana I thought like an orthopedic surgeon. I still do. And I love my neurosurgical and orthopedic spine partners. I mean, we work very closely together, and the joint partners. So we all have a job. We all have a duty for our patients that we want to fulfill. But when I got in the minimally invasive spine world and I was doing some products that I thought were pretty good, I was going down a pathway I was much happier. I'd kind of gotten burned out on some of the basics of pain management, especially dealing with insurance and other things like that, having trouble getting some things approved I knew would help patients. But I was getting kind of burned out, quite frankly. And a little pandemic hit our country, right? And around the time of the pandemic, my voice of reason, we all have a mentor and a voice of reason. Mine's Doug Beal. Mm-hmm. And Doug Beal called me up, and I teasing a little bit and say, he called me up, he goes, "Stevens, 2 words, Minute Man." And I went, "I'm pretty sure that's just one word, Doug." But I said, "I'm not going to argue with you." But he goes, "What about it?" He goes, "I think that's what you're looking for, Chad." And he goes, "I know you're doing some other products, some other minimally invasive products that you're getting good results, but you're not happy with the long-term, durability of some of those. So you need to look at Minuteman." And I got on some webinars like during COVID, started doing some cases after COVID. And what I realized is that I was really enjoying the outcomes I was having with the Minuteman device and SI joint fusions. And I realized that I was more of a stabilizer than a stimulator. And I think that we all kind of fall into categories, but I want to talk a little bit today when we get to it about how pain doctors need to not paint themselves with one brush. Mm-hmm. We need to not say, we only want to do this, and we don't even have to say there's only one treatment available for each patient. Some patients are going to require multiple different therapies, maybe even combo therapies at the same time. I know that sounds like a mind blow, but that's what we've been doing in the surgical fields for a long time. Mm-hmm. They've been doing a laminotomy and a fusion, or a decompression and a fusion. So I don't want us to get stuck in the pain world of saying we got to use this or that product. And so that's kind of what I want to talk about today.
Yeah. No, I love your perspective, the blend of just having that like sports background and pain management.
Yeah.
Like I think that really has led you uniquely in this space where you don't just want to manage something ongoing.
Yes.
But let's look at the core of like what's actually happening biomechanically in the spine.
Yes.
And I think if I'm hearing you right, that's kind of what led you to Minuteman and some of these other MIS therapies, right?
Yes, it is. And I kind of left out one key part. I think if all of us are honest, our spouses have a big role in the decisions we make. And that morning I woke up after my first Minuteman video, and we did kind of webinar, and I was like, I think that's a little much for me. And my wife said, "Chad, if not you, who?" And I was like, well, what do you, the last time she did that to me was when she was like trying to talk me into doing education because I love it so much. And she's like, if that's what you want to do, then go take some time away from the family on the weekend and teach, because we know you love to teach, And so usually if I listen to my wife and Doug Beal, things work out pretty good. So I want to go on the record of saying those are 2 people I listen to. I don't listen to everybody, but kind of like the E.F. Hutton commercials, they used to say, when E.F. Hutton talks, people listen. Yeah. I recommend if your wife's talking to you or your spouse, or if Doug Beal's talking to you, you should listen.
You got to listen.
Yeah.
Well, you listened.
Yes, sir.
And you kind of pivoted your career to more of these MIS offerings.
Right.
And so that's what we're going to talk about, I think, today. But so you mentioned the combo therapies.
Yeah.
What do you mean by that?
Well, I think that whether we try to or not, and whether our fellowships try to or not, we try to put each patient into a category. and say, oh, that's a patient that's going to need a stimulator, or that's a patient that's going to need a fusion, or that's a patient that's going to need a mild, or that's a patient that's going to need a disc procedure. When in reality, a lot of those things may be needed for the same patient at the same time, right? But for some reason, probably because insurance makes it difficult, right? Not that I want to cap on them all day, but just they can make it difficult to get multiple things approved. But when a patient presents a certain way, we don't want to put them into just one category. We want to say, okay, here's their symptoms that go along with this, and here's the symptoms that go along with that. Because what doctors do a lot of times, I mean, even on simple things, like when you think it's going to be an epidural that's going to help the patient, it ends up being more of a facet-mediated pain.
Yeah.
Those things you kind of kick yourself for, but why kick yourself? Those are two very different kind of patients, but they may have overlapping symptoms, right? And so I think as I've gotten older, and you mentioned that I'm old, I've been doing this for 25 years now, Parker. One other thing I've learned is that I don't want to put everything into an algorithm. I don't want to put everything into if this, then that. Well, granted, if you have like mid-level providers, it helps to have, some sort of a direction to point them. If they didn't do well with this, then move this direction. But what I've come down to is these are patients, for the most part, my practice, I have sports medicine people, but the people I'm doing the minimally invasive procedures are mostly, the 65 and up crowd, right?
Yeah.
And they're people that have spent their whole life creating a life for themselves where they're going to go fill their dreams, right? I'm going to get to this point in my life and I'm going to travel and my wife are going to do this, my husband and I are going to do this. But what I see happening, Parker, honestly speaking, is they get to that point and all they do is go to doctor visits, right? It's like Monday we're going here, Tuesday we're going here, and they plan their day around it. They're like, oh, sorry, we can't do anything on Wednesday because we have to go to the doctor at 10 o'clock. Well, what are you doing the rest of the day? Well, that's what we're doing on that day. Because they've now come to a point in their life where they either worked hard or played hard when they were younger, and maybe they did or didn't take care of themselves, or maybe they abused things or didn't abuse things. But whatever that situation, when they get to that age, there's a degenerative spine issue that's going to catch up to all of us. And I've already, I had back surgery when I was 37. I mean, I'm not just the president of this, I'm also a patient, right?
I didn't know that.
Yeah, I did. And one of my partners in Indiana did it for me.
Yeah.
Shout out to Al McGee. Thank you, brother. You did a great job. Haven't had a problem. Haven't had a problem since. Haven't had a problem since.
Yeah.
But I do understand a little bit what my patients go through because, I've seen families over and over get to a point where they're ready to live their dreams. And so part of what I get to do, Parker, and what we do as pain doctors and as surgeons is we get a chance to help the people get back to the dreams they were growing up to fulfill instead of just watching them just dwindle in a downward spiral. And I know that sounds a little bit negative. I don't mean it that way. I'm trying to make it a positive that one of the goals we have, and it gets a little bit laborious sometimes. You see a lot of patients, you have a lot of difficult patients, you have a lot of different things happen. Sometimes it's hard to remember why you went into medicine in the first place, right?
Yeah.
Nobody went into medicine to make somebody else's life worse. None of our interviews do we say, my goal is to do something. I'm gonna give people a bunch of medicines to get them addicted.
Yeah.
Nobody said that, but it's happened before. And nobody said I'm gonna give somebody a medicine that's gonna have a side effect that's gonna cause them to have a pulmonary issue. I mean, we don't do it for those reasons, but we need to be looking for ways we can help people with a mechanical solution so that they can get back on a track of where they can live those dreams they want to have.
Yeah.
Does that make sense?
Yeah. No, I love your compassion toward the patient in that way. And I think we talk often about the aging spine.
Right.
Right. And I think that demographic of patients, even in the past 5 years, they now have tools, or you guys have tools as physicians to be able to help them when you didn't have before. So maybe talk a little bit about the evolving of, you mentioned in the introduction, things have just changed so fast in the past 5 years that you guys have tools in your toolbox now to be able to help that demographic specifically, right?
For sure.
So maybe comment on that a little bit.
Okay, so let me digress just a touch.
Yeah.
We talked about combo therapies. Let me be a little bit more specific. When you think, like a little word association game, when you think about somebody that has modic changes, what do you think? You think intracept or some sort of basivertebral nerve ablation, right? When you hear somebody has atrophy of their paraspinal muscle, specifically the multifidus, you think, well, let's go get a reactivate, right? So there's this paradigm shift where people are seeing this, then it must mean this, right? And so I do think, there's a lot of procedures as well as decompression treatments, with mild and the like. There's a lot of things that are going to be helpful for our patients, and we don't always have to pick which one is going to be the only solution. But I think our job is to be good enough at a history and be good enough at a physical exam to try to give them the best chance the first time, right? And we're not always going to be right. Sometimes we're not perfect. Stories are not perfect, but if we do our very best to seek those out, we'll usually end up with the right procedure. So when it comes to like minimally invasive spine procedures, I'm thinking about another term I want there to be a little word association with, right? We talked about what makes you think of a BVN, what makes you think of a reactivate, both great procedures, by the way, in and of themselves. When you think about instability, you need to be thinking about a procedure that's going to provide a stability solution, okay? And so for the longest time, when we entered into minimally invasive spine, for the first few years, the pain doctors did that. We were seeing these patients that had instability, and we had some procedures we could do to help people, but we didn't have a real answer for people that had instability. So I started looking for that more, just like everybody else, and I put this picture in my head of like a person that has multiple things wrong with them. What would be the first thing I would do, right? And so I've gotten to the point where when I see somebody that has modic changes, it crosses my mind that maybe they have modic changes because the disc height has become so much less, and we'll refer to that as vertical instability or VI through this conversation, or they have so much of a slip, an anterior listhesis, that now their ligament flavum is working really hard, and then they might be a mild patient, right? And then, or the facet is gapping, it's full of effusion, so they have all these pathological changes that are as a result of an instability problem, right? So that's where we go to. So I started down this pathway using Minuteman for my patients that had anterior listheses. I think that's a pretty obvious option for people, especially when they have what we call dynamic listheses, where it's moving more in flexion and extension. I really want to harp on the importance of getting flexion extension films.
Yes.
You can't really talk about instability just off of an MRI. You can a little bit, but you can't tell if it's dynamic or static. So point one is they need to be able to get flexion extension films, read their own films, and see how those two compare, right? So once you have your flexion extension x-rays and you know what you're trying to correct, then you have to pick the right tool for that, right? So I pretty quickly caught on the fact that those patients with a grade 1 spinal listhesis were going to do very well when they had neurogenic claudication symptoms and stuff. They'd be a good Minuteman candidate. What was really eluding me, just honestly speaking, and I hate to keep talking like I'm having all these epiphanies in my life, but I think that's part of medicine is you start to see things and you start to question, and then you go read and learn and study and look at research, and you can kind of come up with some new solutions. But one of the things that came very clear to me, and I've talked to several of the providers around the country that are really high-end providers, we all kind of struggle with this. How could a patient be having neurogenic claudication symptoms and instability symptoms, and you look at their flexion extension x-rays, and they don't have a significant amount of slip? The bones are still lined up. The little Jenga blocks are still stacked up. How can that be? Classic case of claudication. Classic case of changes in their ability to reduce their pain with flexion and increase their pain with extension. So they have mechanical symptoms on all these things. But when we look at the images, it wasn't what we expected. Because usually the images are kind of the last thing we look at and go, okay, I'm fully expecting this person's going to have instability. I'm expecting ligament inflamed hypertrophy. I'm expecting facet gapping. And then we see it and we go, okay, yep, there it is. But there were these patients that had these symptoms that didn't have any findings that we could really fall back on. And this is when we started to think about what is really going on with these flexion extension x-rays that we can glean from, okay? And I want you to hear the term angular instability. You guys have probably talked, I haven't heard every one of your podcasts, so somebody's probably already touched on this, but I do think this is an important concept.
Let's talk about it.
That when you start to look at your flexion extension x-rays, you may not have a slip in this direction here, but you have an opening up, a gapping where the posterior elements are much tighter than the anterior elements. And so it looks like a Pac-Man mouth. And so we've gotten to a point there where the disc has degenerated. This is your aging spine, so to speak, you're talking about, and the degenerative changes in the over 55 or over 65-year-old person. So what has happened now is the disc has degenerated. All the pressure is posteriorly now, and it's causing compression of the nerves. So the bones are no longer able to protect the structures that are inside them, the nerves. And so those are the patients that I think are going to be candidates for us. But when I wasn't aware of this angular change, it was really puzzling to me. So you start going back to some of the like United has a policy that says if there's more than 11 degrees of that angular instability, they consider that to be an instability. The same as they also consider it to be, if you have more than 3 millimeters of a dynamic slip, they consider that to be instability. So when insurance payers and when documentation is saying this angular instability is a real thing, and we're seeing the ligament flavum hypertrophy, and we're seeing the gap in the facets because of that instability, it dawned on me that these are probably patients that could be good candidates too. And yeah, I missed some of those patients along the way because I didn't know that, but I'm hoping to proclaim that and help other people learn that, so that when they see those angular instability patients that meet the criteria for the procedure, that they start to consider a stabilization device for that.
Yeah, and it's such a great point, because when we think about angular instability, that's a finding in flexion extension that really wasn't being looked at very often.
Right.
And so when you translate that to, no pun intended, when you translate that to the word instability,
Yes.
that was thought of as something that needs a bigger surgery in the
Yes.
past, right?
Yes.
And so now we have these interventions
Yes.
that you can help a patient with that's maybe not a bigger surgery. Certainly there'll be some
Yes.
that need bigger surgery.
Yes, there
we
still
know
are.
that. But this is an opportunity now to treat that aging spine
Yes.
with an intervention that wasn't there before.
That's right. And a lot of these people, Parker, because of the aging spine goes along with the aging patient, there's a concept for you, right?
Yeah.
They're going to have comorbidities. They may be a little overweight, or they may have bad hearts, right? They may not be good candidates for a extended surgery where they could do something that only takes 15 to 30 minutes and give them, I hate to put a time on it, but something a lot less time of anesthesia and a lot quicker recovery for a patient that has, segmental problems more than a multi-level instability and big scoliotic curvature and things like that. So I do fully want to stress that I work closely with our spine surgeons. In fact, I get a lot of these patients referred to me from the neurosurgeons around me. And so I don't want anybody to get the idea that everybody's a candidate, but I do think that pain doctors need to start thinking about, the patients that we've put in the past on narcotics or just a therapy plan, or the epidurals that stop working as long or don't work at all. Those we need to have a plan to adapt to next, because if we don't, then they're going to go down the street and they're going to find somebody who does. So part of the education process, Parker, is letting our colleagues, yes, in the same area as we are. I mean, a lot of my colleagues in our area do the same procedure, and that's great, because the more of us that are doing these things, the more the patients are getting treated that were maybe before kind of on outside of treatment. Maybe they weren't very good surgery candidates, or maybe they didn't want surgery. Some people think of the word fusion and they get afraid and they don't want a big surgery. Maybe they have a friend that, in the Metroplex, we had a person that was it's a podcast that talks about bad outcomes from spine surgeries, right? And maybe they've heard about that. And so I think that there's an education with our patients. I think there's an education of the physicians. And honestly, Parker, that's what I've become so passionate about is, I just want the next generation of doctors to know, a lot of these doctors that I've trained are 30 and 35 years old, and they're where I am now, 55 years old, with their understanding of the direction they're going with their careers. And I'm so excited for them, because the people that are going to benefit from that are the patients.
Yeah, we had one of those doctors on our podcast a couple of weeks ago, Dr. Andrew
Dr.
Phillips.
Yeah.
Spoke highly of you, and he was thinking he's kind of on that same track where he's now learned what angular instability is earlier on in his career, and he's able, like to your point, he's able to help more of those patients now.
Oh, yeah. He's 15, 20 years ahead of me, really. Because I think he came out with, I'm glad you brought him up, because I think he came out with a desire to do more than the fellowships teach, and the ability and the talent to do those things. And honestly, like I said, my first plan was to coast. Not coast like lazy, but like just do the basic things.
Because manage the pain.
Yeah, in my group in Indiana, I did 60 or 80 epidurals a week, but no big cases other than like some stimulators and kyphoplasties. And so I started doing a lot of kyphoplasties there because of the need for the group and things. But I really realized when I was there that there was so much more that I could do. But I was already, getting up in age by then. So, and these guys that are coming out and they're going to society meetings and they're trying to figure out what is the newest, latest, greatest thing. It's an exciting time for pain fellows and pain physicians, to be honest with you.
Yeah. Dr. Phillips met a couple of physicians at Aspen, and they were talking to each other about different therapies like this, and that's kind of what accelerated his career in this. And so to your point, societies make a big difference too, obviously.
I think we need those. I think we do, and they're good advocates for different, therapies. for acceptances by insurances and things like that. And so I do want to advocate for people to get involved in those and because I mean, honestly speaking, all the fellowship directors around the country mean well and they do a good job of teaching the basics. How do you manage complications? How do you interpret anatomy? How do you place needles and other devices in places they need to go? But they don't always talk about the advanced procedures. But candidly, the people that are looking for people to employ, they're looking for doctors that have the skills that are more advanced than just the basics.
Yeah, keeping up with the market and really the demand of the patient too.
Absolutely.
So, okay, let's camp for just a few more minutes on AI.
I'm sorry, I got a little excited.
Yeah. So no, it's great.
Okay.
You explained it well.
Okay.
I want to double click on it because you did such a good job.
Okay, cool. Let's do it.
Yeah. With angular instability, I just want to have our audience have in their mind a patient walking through the door.
Mm-hmm.
Okay. And you've done this a lot now, so you know what this patient looks like.
Absolutely.
Take me through patient walks through the door. And then I want you to be like describing to our audience what that patient looks like initially.
Yes.
And then when you're with them in the clinic,
Yep.
how do they sort of present? How do you know that they're probably going to have something like this?
Yep.
So yeah, go for it.
Will you allow me to use my little quirky little...
I love quirky
all right.
stuff.
Okay. This
Let's
kind of
go.
quirky, I know. Not patented, so nobody better patent this. I haven't done it yet. I haven't had time to do it. I've been too busy. But if you want to improve your Minuteman census, CENSUS, all you have to do is follow your census, SENSES.
Let's go.
Pretty good, huh?
I like it.
Okay,
I like
so
it.
I'll just leave it at that. It's
remember
pretty good. Yeah. Okay. So first you look. You use your eyes. The person comes into the waiting room. They're on some sort of assisted device. The receptionist is calling back saying, Stevens, we got a hot one. Not like a good-looking person, but like a person that may be a patient. You know, I mean, maybe they are good. But the point is, somebody that may be a candidate because they are using some assisted device. And even my receptionist knows and my MAs know that when a patient is leaning over, that is an indication that they're trying to treat themselves by opening up their spinal canal. So we already know that that's probably a patient that's got some sort of spinal canal narrowing, right? So we're looking at them first. We're looking at their gait. We're looking, do they have a limp? A lot of the things we pick up on the SI joint, to go a little different direction, are things we see on their walking gait, right? So we're looking at the patients, looking at what they do. When they walk in my exam room, do they lean on the counter? Do they lean on the bed? Do they sit leaning forward? Are they in a wheelchair? Do they have a walker? Do they talk about sitting, in a lazy boy to sleep? Those are all things we're looking for, right? Okay, then we listen, okay? This is probably the hardest part for the doctors. Maybe touching for some of them, but listen is next. So we let the patient tell us what is their concern. Well, my concern is that I'm an 80-year-old person who spent my whole life raising my family, and now I can't even walk all the way to my grandkids' baseball game. Got it. Her or his goal is to walk to the game without having to stop at every bench along the way. Okay, they are telling you that they have some sort of a claudication, right? Now, those of us that have a vascular background, to shoot a little, toot my horn a little bit, my vascular days of being a vascular technologist and being called the Doppler boy. I know that sounds a little bit like they were hazing me. They were probably, but
That's not your nickname still, is it?
no, Rad Chad,
Rad
Dr. Rad Chad. Yeah, pretty soon, Dr. Rad Chad Granddad. That's gonna be my name. Yeah, we'll get to that in a minute.
Yes.
But so, when we're looking there is if somebody's walking along and they stop and they have to sit down to make their pain go away, they're probably trying to tell you they have some sort of a neurovascular problem, right? And it's probably more a neurogenic claudication. If they can walk a distance and stop and stand there for a few minutes and the pain passes and they can walk again, it's probably more of a vascular problem. So we're listening to our history going, okay, what is it they really are wanting out of this? What are their real problems they want solved? And how is their history impacting their life, right? What are their goals? So maybe they want to be able to climb, maybe we're in Tempe, Arizona, they want to be able to climb a mountain, they can't do that, whatever it is, right? And then the next thing is we touch. We use our hands and we feel. This is an art that used to be used in physical examination, and a lot of times we're just in a hurry and we get away from it. The amount of times I'm talking to a patient and say, I'm going to make you do this, this, and this, and I'm sure you've done it 1,000 times. You've been to a lot of the doctors, and they say, no, nobody's ever made me stand on my tippy toes or my heels or bent me backward or forward. I mean, there's a lot to be gained by just doing a physical exam. So if I stand them up and I lean them back, their pain increases, and I lean them forward, their pain decreases, then I know I'm on the right track. Now, you might think that there's like some overlap with facetogenic pain, and there is, but facetogenic pain is like you, right? You're not quite a candidate for a minimally invasive procedure. You're more along the lines of maybe a facet pain, right? Because of all your basketball years and all those things, right? So but that's still a clue. And then the last thing we do is we look again. We look at the images. And the images, we're looking at the MRI or CT scan. We're looking at the flexion extension x-rays, and we're looking for what we expect to see based on those other senses we've used. Mm-hmm. And so that's my little cheap and easy way of remembering what those patients look like.
Yeah, that's a good way of visualizing it and then just slowing down, taking your time.
Absolutely.
And I love the sports medicine background coming out in you in that. And so that's fantastic.
Thank you.
Okay, let's shift gears just a bit on, now we've identified a patient with vertical instability, angular instability. You've seen them in the clinic, you've seen an inflection extension.
Yes.
So how does a procedure like Minuteman, lift and balance that segment? So what does it actually accomplish?
Yeah, so
coming in laterally first, obviously.
Yeah. So I think we'd highlight that. So some of the benefits of this procedure itself are with the Minuteman, you're sparing the tissues that are there to provide stability, right? So when we were doing other procedures, we were going through the back directly and cutting through the multifidus muscles and causing risk to devascularization and denervation of some of those multifidus muscles. We were putting ourselves at potential risk for future problems, and luckily now Reactivate came along for things like that to help us with it, right? So it's again a combo therapy, but when we're coming in laterally, we're sparing that supraspinous ligament. The supraspinous ligament, one of its jobs is to keep that slip from occurring, right? So we're sparing that, first of all, right? The key to the balancing is that we're keeping that ligament intact, like a wheelbarrow, right? Because we're keeping that intact, when we then put the device in posteriorly between the spinous processes, it allows the lift of those. We talked about the angular instability. So it's like this. We want the end plates to be more balanced. And by lifting, putting the device in like extension blocking, what we're doing is we're actually lifting these end plates. And because that ligament is still intact posteriorly, it works as a fulcrum so that it keeps them in that position. What our patients are trying to do, Parker, all the time is find a position that will open up their spinal canal more, right? Mm-hmm. That instability, that neurogenic claudication manifests as pain when you're walking or standing a distance, right, where you have to sit down. So what we're doing by doing that is we're opening up their spinal canal and we're opening up their foramen. And by lifting it, what we're actually doing, we talk about vertical instability. We can oftentimes, almost every time, see on our post-op images that we've lifted up the disc height again. It doesn't mean that I've completely restored a disc. I'm not saying that. But I do want to highlight that vertical instability where the brake pads are touching each again, where it's like we put another pad in there, because when we put that device posteriorly and in the right patient, what it does is it balances those end plates again and it lifts that vertical height. So you get that vertical instability correction, you get that angular instability correction, and it's durable and sustainable.
Yeah. Fuses, right?
Yep. Absolutely.
Yep.
It's a fusion device. That's right.
Yeah. I've had the privilege of being in the OR with you, and when you look at the lateral, pre-lateral post,
yes,
you can see that posterior end plate just aligned as the device is going through that segment, right?
Yes.
And so that's what it does. It lifts balance and then obviously secures it.
Yeah, and I'd love to say that it's our superior skill that does this. One of the things that's nice about this procedure is that when we teach doctors to do it, it's not nearly as complex as the other things we used to do. People think that myself, I thought this is going to be a little hard for me to learn because it's a lateral approach and stuff. But now that I'm doing this, I think it's a lot easier than a lot of the other devices I do. Definitely more reproducible, and it can be done by all shapes and sizes of doctors because the device does all the work. And that's what I love about it. You kind of gave me a nice little shout out there that our cases went well, which I appreciate. But really what happened is I followed the steps, one till end, and that we teach every time we teach a lab. And that's what does the balancing and allows the product to work appropriately.
Yeah, that's fantastic. All right, we're going to take a fun little break that I did not prepare you for on purpose.
Okay, let's do it.
Because I've got some fun rapid fire questions for you.
Oh gosh, I'm nervous. Okay.
Rapid fire questions.
All right.
Okay. First thing you look for when a patient walks in the room, what do you look for?
As far as I'm trying to figure out what it is that they want and need.
Okay.
Because my goal, it may be that I have a tool that could help somebody, but if that's not what they want in their life, then it's a waste of time for them and for me to talk about it.
Yeah.
So I want to get to know my patient. And I know it's a little bit maybe off the path, but I let them know a lot about my family. A lot of my patients have met my family. Maybe my wife had to fill in one time or something at the receptionist. I mean, most of my patients know my kids' names, know their hobbies, know the things. And so I owe that to my patients to learn about their, what are their grandkids doing, or what are their kids doing, or what are they doing in their own sport. And so first thing I look for is a commonality where I can make some improvement to the condition they're presenting for.
Yeah. It goes back to your point earlier of listening.
Absolutely.
Right. You listen to what they're telling you.
Absolutely.
Yeah, that's a big deal. All right. If your kids took over your clinic for one day, what's the first thing that would go wrong?
That's an interesting question. So I think what my kids would do is they would try too hard.
Yeah.
I think they would want so badly to please their old man that they would want to take excellent care of our patients.
Yeah.
And what a lot of times the patients need is somebody to listen to them.
Yeah.
There's a lot of times, Parker, this might surprise you, that 3/4 of a visit is about just hearing out what's going on in their life and talking about the divorce they're going through, or the kid that's struggling with an addiction, or whatever else. And I think my kids would probably be so interested in like trying to do such a good job that they might mess up a little bit of that. But on the other hand, I think my wife and I have taught them well to meet other people's needs and the importance of being kind and fair to others, that they would probably catch on. But if they followed me for a day, they would come out of the room and they'd go, "Dad, we talked about 5% of that visit about the person's, problem, what they're going through." And I'll say, "Son or daughter, what we did is we were the person this week that they need to come talk to, and I'm not their psychiatrist, but they needed to tell somebody." And if I would have cut them off and not listened, like some people might be prone to do, or I might even be, prone to do in some situations, then we might miss the whole purpose that visit was for. It's not always about putting somebody on the OR table and doing something procedurally to them. Sometimes it's just as simple as saying, "I see you. I understand you have real problems." And Parker, you could be in my office between 7 and 10 in the morning. I always joke with my scribes. Both my scribe and my medical assistant are both pre-med students right now.
Okay.
I have a really, really power-packed team. And one of the things I'm teaching them, I hope, is that by 10 o'clock in the morning, you've seen more problems than you might have for a month in your life. People really do have problems, Parker, and a lot of those are patients that present to pain clinics.
Yeah.
And they may not even know why they're really there. Sometimes they come in and they say, "My doctor referred me here. I'm not even sure why I'm here." But our job is to tease out a little bit what we can do to help them morally, spiritually, physically, whatever it is they need, and to apply the skills that we've been given to do so.
Yeah. Taking care of the whole patient. That's really good. Is that something you learned along the way, or have you always treated patients that way?
I think that's probably just the way I was brought up.
Yeah.
My parents were both great examples to me of putting. My dad was an accountant, and my mom was a teacher, and I don't remember very many dinners at. We had something called a telephone that had a cord.
Yeah.
And we sat at something called
Landline.
a bar.
Yeah.
Food came across the table. We sat on a bar. Dad sat by the phone. And almost every time, and this is going to sound a little bit, this is not meant to be a negative thing. My dad was an accountant and he was an elder at our church.
Yeah.
And there was almost no dinner we had that somebody didn't call, either somebody from the church or somebody from accounting that needed my dad's advice. And my dad never said, everything's just, this is, he wasn't really good with boundaries. And I've had to learn that. And my wife's been really good at helping me learn that. Still got a long way to go on that. But my dad's role, in his opinion, was to help people with the skills he was given.
Yeah.
And I watched that. I learned that. I think my sister, who's a financial planner, who does a lot with deals a lot with people. I think we learned a lot about taking care of people from our mom and dad.
Yeah. Yeah. It sounds like it. Sounds like you absorbed that skill set for
Absolutely.
sure. Yeah. Okay, what's one thing you would absolutely dominate at on family game night? Do you guys play family games?
Yeah.
Yeah.
Definitely no question Songburst. So
No question. Didn't even have to think about it.
Yeah, because I'm not the person you want on your like Trivial Pursuit team unless it's sports or medicine.
Yeah.
There's nothing else I know about.
Yeah.
I can't even tell you like where a state is in the union, okay?
Yeah.
So I'm not the guy you want.
Yeah.
But I have a pretty uncanny memory of lyrics from songs from the 80s.
Oh, funny.
And from
You
all through
dominate
the
that.
years. Yeah. So I would say my kids would say that, taking away all the new dialect that they're using, I can't understand half of it.
Me either.
Right. So Gen Z, whatever.
Yeah.
But the true old 80s music and the songs like that. My brother-in-law, who's a basketball coach, who's also a pretty good people person.
Yeah.
He and I dominate that. And also Christmas Vacation movie quotes.
Let's go.
We are pretty good at that. Now, all the other stuff that doesn't even fill our brain, right? It's like you can read a book and forget it tomorrow. But I can remember those quotes.
That's awesome. What's your favorite quote from the Christmas movie?
Oh gosh, that's a tough one.
Yeah.
Let me think. Probably. And how did the floors get wet, Todd? I don't know, Margot. That's probably it.
I love it
because that was pretty good. Where Julia Louis-Dreyfus then gets punched out. That was a pretty funny scene. And so, sadly enough, I'm really embarrassed to say I need to start making it part of my criteria. My new scribes that I told you were so excellent, haven't even seen the movie. One of them had a date night with his girlfriend and watched it.
Yeah.
The other one still hasn't seen it.
Yeah.
And I tell them, get the TV version.
Come on, let's go.
And watch this with your family, but not just the TV version.
Yeah. Okay. Well, last question on the rapid fire, which is turning into be less rapid fire on my part, but
no, I'm not a short answer guy.
Super interesting.
Yeah.
Okay. If you weren't in medicine, what Texas job would you pick? Okay. I'll give you 3 options: rancher, barbecue pit master, or high school football coach.
High school football coach for sure.
Okay. Why?
Because I've been helping coaches for a long time. As a team doctor at multiple high schools, sometimes the coaches just need a little nudge.
Yeah.
I'll give you an example. I got penalized on a play against our rival team. There was a thing where they were having these replacement referees. Do you remember that time?
Yeah. Oh, yeah.
And I didn't say this. I will go down to my grave saying this, but somebody behind me in the stands yelled, "That was a call even a replacement referee could have made." And the referee looked right at me, and he looked right at my coach, and he threw his flag, and I went, "Oh no, this is not going to go well." So the coach was not. Luckily, Jason Witten wasn't the coach yet there.
Yeah.
I haven't had the pleasure of being a team doctor with Jason there.
Yeah.
He's an amazing coach, but I had already switched into like teaching mode and being gone on the weekend mode for that. But the coach at that time, he didn't speak to me for a week, and my son was on the team.
Yeah,
and he'd come home, he'd go, "Coach is still mad at you, Dad." I'm like, I didn't say it, but all along the way, because the coach can only go down to the 20, right?
The little box.
The doctor can go all the way to, sometimes it's a 35-yard line, right? That's where they box them in. I can go all the way down the line. So I do chew on the referees just a little bit all the way down the line.
You're an extension of the coach down the line.
So there are times where I think that my suggestions were probably never taken by the coaches, but in my mind, I might have contributed a little bit. But the reason, on a serious note, I think all those jobs you mentioned can make an impact on people.
Yeah.
But I've seen the impact that the coaches at Liberty Christian have made on my kids.
Yeah.
Every one of my kids had an amazing experience. Just last night, my daughter took her picture off. They made her take the picture off the Wall of Fame because she was a cheerleader in Division I school, and they honor them. But if I were to walk into the school and talk to the principal or the coaches, they know all my kids' names. They know all the experience they've been. They know where they went to school. They know that Connor is a medical device. They know all those things.
Wow.
And so I think football coaches and coaches in general, and again, my brother-in-law was just put into the Hall of Fame for basketball as a coach and a player in Texas. Wow. And I was texting him just the other day. I was like, Darren, we've had different roles in people's lives, but he was telling me about how he's had all these things come up where he's had to sometimes be a parent to the kids, and sometimes the parents were difficult to work with and things like that. And I think when it comes right down to it, it takes a village to raise a child, and I'm so thankful for the coaches that helped me raise mine. Yeah,
that's great. Yeah. Doesn't surprise me. That's what you picked. Very good. All right. Let's go back into AIVI.
Okay.
And have a couple more questions here.
Sure.
As we think about patients with angular instability, vertical instability.
Yes.
I want to double click a little bit on imaging for just a moment.
Sure.
And what you're looking for in an MRI or flexion extension. What are the kind of the call outs when you know that someone is going to be a candidate for Minuteman, whether they have angular instability or vertical instability? What do you look for?
I've kind of been dropping hints through the whole podcast.
Yeah.
Let's go ahead and put it into something that makes sense.
Yep.
So when you have a patient that has instability, the body is going to try to correct that on its own. Okay. So there's stages of degeneration. Like we put them into 3 different stages. I think it's Kirkcaldy, Wildis, those guys that put them into 3 stages. The people that have moved on to what I call the hook 'em horns phase, no pun intended, because the Aggies did lose to UT.
I saw that.
Yeah.
Yep.
Yeah. So, but the hook 'em horns phase is where those osteophytes have grown to where they're like connecting the vertebral bodies. Those people are at a stage that's probably a little bit past where we're going to get any kind of changes. And so I want to kind of rule some of those people out.
Yeah.
So I look at the x-rays to see, are the degenerative changes, so demonstrative that it's gone on too far to be correctable, right? So I want to use my flexion extension x-rays for that. I also want to look at my flexion extension x-rays and go, is there a slip that is more than a couple millimeters? And if so, could there be an ongoing pars fracture, right? Not a pars that's healed, but a pars that's continuous. And obviously that would rule them out for a device posteriorly, right? Because the bone would keep moving forward. So I'm looking at that. Do I need to get a CT scan to confirm that? And so the flexion extension x-rays are for looking at those things plus pre-op planning.
Yeah.
They also help me go, okay, if I'm going to put a device in somebody, it's going to be a more permanent thing. I call this thinking like a surgeon. And I appreciate my colleagues that are surgeons because I know they do a lot of pre-planning, and I really teach that to the pain doctors. We got to do a better job of that. But I want to know before I even go to the OR that day what I'm expecting to do with this device. And is the patient going to be better served by being in more flexion or more extension? And the flexion extension x-rays also show me that. Okay. So lots of reasons for the flexion extension films. Now, when I go to the MRI, I want to see those secondary signs of instability. The ligament and flavum hypertrophy, we talk about the magic number is more than 2.5 millimeters of bulging, right?
Yep.
And Dr. Kloster, one of our colleagues, does a really good job of describing sitting in the middle of a room and getting closed in from the front and the back and the sides, and that's what's happening to their spines, right? So that you can show people that on their axial image on their MRI. I usually say something like, okay, if you have a weak stomach, you better not watch this next picture I'm going to show you, because I go from the spinal canal, it's like this, and I show them the spinal canal is now like this. And they go, why is that? Well, the disc is bulging backward, and the ligament's moving forward, and the facets are hypertrophic, and they're coming in from the sides. So all these barriers are coming in to cause your spinal canal narrowing. And so I'm looking for those findings. The effusion or bright fluid inside on the T2 axial images on the facets, the ligament flavum hypertrophy. We're looking for those secondary signs of instability vertically, like the modic changes, right? Where the edema has formed in the implate, like a knee that's bone on bone, but it's in the back. And so that bone on bone has caused inflammation and edema, and it shows up as white patches on your T2 and your STIR images. So those are kind of the main things I look for. And I think you can probably tell that I put a lot of time into learning how to comfortably read my own images, because a lot of times insurances get something sent to them that says there's no instability, not no dynamic instability, but no instability at all. Therefore, they're not a patient needs a stability device. But when I talk to the peer-to-peer or whatever I'm doing, and I'm talking to another doctor and I'm telling them what I'm seeing is at the L4-5 level, there's a gap, with this angular instability of about 15 degrees. And I think that's why on the MRI, we're seeing these secondary signs. And that is understandable to the people that we're talking to. And I think that should be understandable as we're training people to say, okay, I've seen those patients, but, we always say, you may not have seen them, but they've seen you.
Yeah.
That's the patient where you went, my gosh, I thought they were here for a device, and I got their images, and it wasn't a good candidate. Why? Because there was no Jenga block offset. But even though there wasn't a Jenga block offset, there's angular instability, vertical instability that they could benefit from a device like a Minuteman.
Yeah, well said. Well said.
Thank you.
Okay, as we think about winding this down just a bit, I want to really hone in on aging spine care. Okay, so for a physician who is listening to this, maybe they've actually started using Minuteman a little bit, or this is the first time they've heard of this concept of angular instability, vertical instability.
Right.
Maybe give them one or two things after they listen to this that they can go do in their practice on Monday. So what's important to them? They're hearing you.
Yes.
They're going, man, these are some patients that I just have not even thought about.
Yes.
What do they do now after this?
Touch their patients.
Okay.
If your patients come in giving you a story that sounds consistent with instability or neurogenic claudication, examine them. And I know that sounds simplistic. I wish it wasn't true, but stand them up. Put your thumbs on their PSIS, which is, very palpable. The thing that people think is wrong with them, where there's a bone sticking out, it's supposed to be there. And I tell people, put their thumbs there and put their long fingers on their greater trochanter, and then have them extend backward and have them lean forward. And the patients that decompress themselves and their symptoms resolve, those are patients you need to be thinking seriously about looking deeper into, getting the workup we've talked about with the imaging studies, and maybe even, doing some other things. We haven't really got into it, but trying other procedures, maybe even like epidural injections at the same level to see if if there's a couple levels you're not sure of. Then you have to decide what level is the most important level. And so sometimes we use our epidurals and things like that. But they're going back to the basics, Parker, is where it all starts. Listening to the history, examining the patient by actually physically touching them, and then using those things to base the direction you go with your workup.
Yeah, I love that. Get relief in flexion, forward flexion. Yep. Get some flexion extension X-rays and just examine them.
Absolutely.
And listen to them like you've been saying all along. So that's really good.
Definitely.
I learn something every time I talk to you, Dr. Steven. This has been a pleasure. Thank you so much for being on our podcast. We have to stop.
We can't keep going? Oh, man.
Part 2 coming up sometime soon.
It's a deal.
I love it.
Thank you, my brother.
Thank you.
Appreciate
Thanks,
your
Dr.
time.
Stevens.
Absolutely.